On this episode of the ASC Podcast with John Goehle, we discuss the just-released 2021 CMS payment rule for ASCs and HOPDs, review some recently released guidance related to the Paycheck Protection program, and in our focus segment, discuss electronic medical records with Daren Smith from Surgical Information Systems. This episode of the ASC Podcast with John Goehle is sponsored by Surgical Information Systems. SIS provides cutting-edge information solutions for surgery providers. For more information, visit sisfirst.com. Welcome to episode 111 of the ASC Podcast with John Goehle for August 5th, 2020, recording from our studios in Spencerport, New York. This is Susan Cronkite, Chief Researcher for the ASC Podcast with John Goehle and Senior Nurse Consultant for Ambulatory Healthcare Strategies. Joining me is John Goehle, Chief Operating Officer and owner of AHS, recognized as one of the nation's leading experts in the ambulatory surgery industry.
So we're having all kinds of challenges with our microphones and our board and our headphones today. So hopefully everybody can hear this, right? We hear this hum.
Yeah, and the sound keeps cutting out in our headphones, but I think it's coming across okay.
Yeah, it's because of that $1.25 device over there. I think that's causing the problem, the splitter of all things, the cheapest
Well, maybe
thing.
if you would just spend $2 on the thing.
Well, you know how cheap I am. So today's August 5th. Something going on today. What is it?
I don't know.
Well, for those of you in the world that don't know this is my 60th birthday. So,
for those of you in the world that don't know this,
which is most of the
it's
world.
big news. Why they didn't broadcast it, I don't know.
I don't know. Sue treated me to all kinds of wonderful keto desserts instead of a
I
big
didn't
cake.
bake them, but we have a good keto bakery around near us, and so
I was just thinking, though, it is nice that even, being on a low-carb diet like keto, that you can still find something that's really very good tasting. I still would like to have my, carrot cake, though, my favorite thing in the whole world. Nobody's been able to come up with a really good carrot cake recipe.
No,
for
I haven't
keto.
seen that out there, but my daughter also baked some chocolate cupcakes,
That's right.
keto chocolate cupcakes last night, so it's kind of an early birthday cupcake.
I am very well treated here, and of course the puppy is also helping me to celebrate my birthday. So, why I chose to record an episode on my birthday, I'm not quite sure, but
just so you could announce to the world
that
that you're 60 years old.
Don't know if that's something I really want the whole world to know. Well, we're trying to get back to our interviews finally, trying to get back to some semblance of a normal life here, and so we did have an opportunity to have a discussion with my friend Daren Smith over at Surgical Information Systems. So we have a nice episode here where we're going to talk about electronic medical records, which is a topic we don't talk about that often, and certainly a lot of things going on, and thought he would update us on that. And Sue, I was just thinking, we're planning a virtual conference for New York State right now, actually heavy into the plans for it. And I know that last episode we mentioned that we haven't found any other conferences. We're not getting any emails from people about this. So please, I know we're going to ask it in our third segment, but if you have any information about upcoming conferences, either live or recorded, please let us know, because that would really help us to keep everybody up to date. I think, though, the problem is people are just really up in the air. I know even with ASCA right now, we're trying to figure out what to do with the winter conference.
A lot of times we stick with local conferences because that's kind of what we see around here, and because we do have a lot of New York listeners. But we have listeners all over the place, and the good thing about virtual conferences, doesn't matter if you're, a faraway state, we can broadcast it for you.
That's
we can
right.
let people know, and they could, sign in for the virtual things.
And of course, go into our ASCPodcast.com. I guess this is a little shameless plug. There are some of the conferences that we recorded during the pandemic. So not that we're done with the pandemic, but during the lockdown phase. So definitely visit there if you need some additional knowledge or AEU credits. Definitely look up there. So, Sue, we got some interesting news, just 3 things, but they're all big items. So, Sue, I know you saw an article in Becker's regarding a conversation with Deborah Birx. Can you talk a little bit about that?
Deborah Birx told CNN in an interview that the U.S. has entered a new phase of the pandemic in which outbreaks are more widespread than they were in the spring. So outbreaks across the U.S. are no longer as concentrated in large cities and have spread to rural regions nationwide, according to Dr. Birx. And she was saying it is extraordinarily widespread, adding that Americans who live in rural areas are not immune or protected from this virus. And she was urging individuals who are living in mixed generational households to consider wearing a mask at home when their community is experiencing an outbreak. And I think that is really important because it kind of started off one way and people felt pretty safe if they were more remotely located. And now it's really just kind of infiltrated everywhere. And you just have to really pay attention to what your local area is going through and when to be especially careful.
Yeah, so does this mean you and I have to wear masks in the house now that I'm 60 years old and way older than you?
Yes, so much older than me.
Oh, well, and we do have a mixed age here, though. But so, I mean, I think this is just an ongoing problem that we're going to have. I know I've been able to see my mother for, months, obviously, because of the fact that I travel so much. And
I did go see my mom today, but it is so tricky. We had breakfast together, so I made sure I sat across the table and I was able to take off my mask, but I wore it when I was close to her. I mean, it's just getting to be so tricky. You have to balance it, because I did want to see her, and then I see my grandkids as well sometimes, and they're not so great about wearing masks. So I think we just keep it very small. We don't have a lot of people that we interact with other than when we're traveling, and then we're always wearing masks and doing the hand washing and being very careful.
Yeah.
But we'll have to watch, if it starts coming more into the smaller towns.
Well, especially since we live in a rural part of New York, even though we visit the city quite a bit. But I was hoping by now we might see a downturn, but that certainly is not happening.
No.
And I noticed also Becker's noted that the test results, it's just not feasible to get those test results on an ongoing basis in 2 to 3 days, which we are finding. As a matter of fact, I think they mentioned in that article 75% of tests are coming back within 5 days. In New York, you have to test any patients that are coming in for surgery, and those results have to be within the last 5 days. So we're fine. I think that 75% number is pretty accurate.
I think it's really tough, especially now that so many people are being tested.
And then the most disappointing part of the article was, while great progress has been made to develop a COVID-19 vaccine, there is no silver bullet and might never be, the head of the World Health Organization said, according to the New York Times. We all hope to have a number of effective vaccines that can help prevent people from infection, said the WHO director on August 3rd. So for now, stopping outbreaks comes down to the basics of public health and disease control, testing, isolating and treating patients, and tracing and quarantining their contacts. Do it all.
And we do thank Becker's. We get lots of good information from them.
Thank you. That's BeckersASC.com if you want to go and check out their articles. So as we talked about last week we mentioned that the 2021 payment rule had not been released. It was released this week. Full disclosure here, I have not read the whole thing. I've only been reading summaries of it. So we will have an episode where we'll talk specifically about it. But here are some overviews of the 2021 payment rule, and I'll put some links on the website to this.
According to CMS, the Outpatient Prospective Payment System, or OPPS, and Ambulatory Surgical Center, or ASC, proposed rule advances CMS's commitment to increasing competition. CMS is proposing several policies that would give Medicare beneficiaries more choices in where they seek care and lower their out-of-pocket costs for surgeries.
So this is a really good development. I think we're finding CMS is really looking to the competitive environment here to try to encourage consumers to look for lower cost alternatives. So the proposed rule takes steps that would allow hospitals and ambulatory surgical centers to operate with better flexibility and patients to have what they need to make informed decisions on where to receive care. They pointed out that President Trump's mandate is to put patients and doctors back in charge of healthcare, which I think we all agree is something that needs to be done, speaking for our ASCs and our physicians. Following through on that mandate entails loosening the stranglehold of government control that has accumulated over decades. Surgeries can be expensive. Patients should have as many options as possible for lowering their costs while getting quality care. These proposed changes, CMS says, if finalized, would do exactly that, help put patients and doctors back in the driver's seat and in a position to make decisions about their own care.
And CMS goes on to say, for patients having surgery, hospital outpatient departments are subject to the same quality and safety standards as inpatient settings under Medicare rules. With this in mind, for 2021, CMS proposes to expand the number of procedures that Medicare would pay for in the hospital outpatient setting by eliminating the inpatient-only list, which includes procedures for which Medicare will only make payment when performed in the hospital inpatient setting. This proposed change would remove regulatory barriers to give beneficiaries the choice to receive these services in a lower-cost setting and the convenience to go home as early as the same day after procedure when their clinician decides such a setting is appropriate.
So this is very exciting. I think that inpatient-only list has been a thorn in our side for years because as technology has changed and as it's become apparent that people don't have to have these extended stays, or in fact, in many cases, I still actually remember the days when, this is really dating me now, when patients stayed in-house after cataract surgery, sometimes for many days. And of course, that changed many, many years ago. So getting rid of the inpatient-only list and really looking at procedures on a case-by-case basis to determine whether it's appropriate in an inpatient setting or an outpatient setting is really a big move forward.
But that's not opening it up necessarily for ASCs.
That's correct. So this is step one. So that allows it to be moving to an outpatient setting. And then the next step after that, obviously, is to encourage if it's going to be in the hospital outpatient setting, then there really is no reason why it can't be on the ASC side. So I think these are one step at a time.
Yeah, a huge step, though, in the right direction.
And certainly in the attitude that CMS has toward the industry and toward encouraging outpatient stays now. So CMS would phase in this proposal over 3 years and would gradually allow over 1,700 additional services to be paid when furnished in a hospital outpatient setting. So again, that's that first step. And then the step after that, as they talk about, they go on. We're not going to read this whole thing, but certainly that's the first step in moving those things into the ASC setting also. And they went on to say that in 2021, approximately 300 musculoskeletal services such as certain joint replacement procedures would be newly payable in the hospital outpatient setting. Again, this is exactly where the industry is heading. This is what's happening with many insurance cases, indeed. And the proposed change would be the largest one-time reduction in the inpatient-only list by far. From 2017 to through 2020, approximately 30 services total were removed from the inpatient-only list. So literally 10 times as many that are going in that direction.
And as we all know, Medicare pays for most services furnished in ASCs at a lower rate than hospital outpatient departments. And as a result, when receiving care in an ASC rather than a hospital outpatient department, patients can potentially lower their out-of-pocket costs for certain services.
They run on to give an example that for one of the most common cataract surgeries currently, on average, Medicare beneficiary pays $101 if the procedure is done in a hospital outpatient department compared to $51 if done in the surgery center. And again, we know all of these things, and it's nice to see this published here, and hopefully this information will get out to the public.
CMS also proposes to expand the number of procedures that Medicare would pay for when performed in an ASC, which would give patients more choices in where they receive care and ensure CMS does not favor one type of care setting over another.
Oh, that's too bad. We would like them to favor ASCs, but it's all right. This is a step in the right direction.
There are other reasons to go for an ASC.
That's right.
Lots of good reasons. So CMS says for calendar year 2021, we propose to add 11 procedures that Medicare would pay for when provided in ASC, including total hip arthroplasty.
What a huge change that is to do, total hips now in an ASC setting. My mother had this procedure done many, many years ago, and to imagine that we can do that in an ASC now. And I've actually witnessed this procedure being done in an ASC. It's absolutely incredible. So it's great to see that Medicare is finally going to allow that. CMS also noted that since 2018, CMS has added 28 procedures to the list of surgical procedures that can be paid under Medicare when performed in ASCs. I'd like to see that number to be more, and hopefully with this, the changes that they've talked about in this proposed ruling, that we're going to see an escalation in the number of cases that are being moved over. Yeah. So I think what was also exciting in this, in the proposal, is that under the new proposed rule, there were going to be two alternatives to proposing these procedures being moved into the ASC setting. Under the first alternative, CMS would establish a process where the public could nominate additional services that could be performed in ASCs based on certain quality and safety parameters. And then under the other proposed alternative, CMS would revise the criteria used to determine the procedures that Medicare would pay for in an ASC, potentially adding 270 procedures that are already payable when performed in a HOPD. Under this alternative, they're going to solicit comment on whether the ASC conditions for coverage, in other words, the baseline health and safety requirements for Medicare ASCs, would be revised given the potential for significant expansion in the nature of services. So what they're saying is they're going to take a very broad approach to this, looking at the types of procedures that can be performed and determining whether they need to adjust the conditions for coverage to do that. So I think this is a very positive step in the right direction. I don't think we want more regulations, but if they are proposing regulations to improve the safety and the efficacy of moving these cases over to the ASC setting, it'll be benefiting everybody. So in the new payment rule, CMS is proposing to add 11 codes to the ASC CPL list in 2021. I'm not going to mention them all here, but we will put them in the show notes here. But those include, as they talked about, the total hip arthroplasty, a variety of implant procedures, and some laparoscopies, as well as some additional lithotripsy cases. So again, very exciting developments. And I think this is good news. No new measures proposed for the ASC quality reporting program. So CMS is not proposing to remove any existing measures or to adopt any new measures for 2023 payment determinations. So
yeah, we have to keep things a little more simple. It has been a rough year so far.
Absolutely.
Glad they're not changing anything.
I'm glad that that's and overall, this is a pretty. I mean, from the standpoint of somebody like myself, this is a pretty boring update. I mean, exciting in the sense that they're indicating that they're moving in a direction I think they should be going. But thankfully, not a lot of major changes, not a lot of major reimbursement issues that are going to happen in this upcoming year. We did get some updates on the Paycheck Protection Program, the PPP. So there was some guidance that was issued. So the SBA, in consultation with the Department of Treasury, is providing this guidance to address borrower and lender questions concerning the forgiveness of the PPP loans as provided in the Corona Aid, Relief, and Economic Security Act, better known as CARES. So I just want to go through a couple of these that I think are important.
So there are a number of questions here in their frequently asked questions, so I'll go ahead with one. If a borrower submits a timely loan forgiveness application, does the borrower have to make any payments on its loan prior to SBA remitting the forgiveness amount, if any?
Yeah, so this is a really good question, I think, as part of the FAQ. And the reason that it's a good question is because we all know everything runs slowly, and getting SBA approval for the forgiveness might take a while in the best of circumstances. I mean, I think there's just going to be so many applications going out there and so much that needs to be done. So I think this is a good question. And their response was, as long as the borrower submits its loan forgiveness application within 10 months of the completion of the covered period as defined in the regulations, the borrower is not going to be required to make any payments until the forgiveness amount is remitted to the lender by SBA. If the loan is fully forgiven, the borrower is not responsible for any payments. If only a portion of the loan is forgiven, or if the forgiveness application is denied, any remaining balance due on the loan must be repaid by the borrower on or before the maturity date of the loan. Interest accrues during the time between the disbursement of the loan and the SBA remittance of the forgiveness amount. And the borrower is responsible for paying the accrued interest on any amount on the loan that is not forgiven. So this is a good development, basically indicating there's a lot of flexibility here, and hopefully people will see. Well, first of all, hopefully people will get their applications in on a timely basis, and we still have some time for that. But keeping on top of this, I don't think will be too difficult as long as we respond quickly.
And another question, are payroll costs that were incurred during the covered period 1 or the alternative payroll covered period 2, but paid after the covered period or the alternative payroll covered period, eligible for loan forgiveness. I feel like that's a tongue twister.
I know, and sorry I made you ask the question. So what we know under the PPP program is that there were two alternatives. One was that you had an 8-week period, and then there was an additional period of time, depending upon whether you're able to use all that funding. And that was a great opportunity for people to extend the length of time. So the second alternative was a 24-week covered period. So if you opted for, depending upon which one you opted for, will determine the coverage period. So their answer was quite simply, if the payroll costs are paid on or before the next regular payroll after the covered period or alternative payroll period, then they will be eligible for loan forgiveness. So again, it's showing some flexibility, or quite a bit of flexibility in this. And they also went on to state that payroll costs that were incurred before the covered period but paid during the covered period would also be eligible for loan forgiveness. And I know that in our particular case, that was one of the issues we had, is I think the loan was actually dispersed midway through one of our payrolls. So this definitely will help us out.
And for purposes of calculating cash compensation, should borrowers use the gross amount before deductions for taxes, employee benefits payments, and similar payments, or the net amount paid to employees?
So as an accountant, this question kind of bothers me because we're always dealing with the gross numbers. So I'm not sure, but obviously these are questions that people asked of the SBA and certainly had to be answered. So yes, indeed, they did verify that the gross amount should be used when calculating cash compensation, which is good for you because obviously the ambulatory surgery centers are paying out of that gross amount for the various taxes, and you wouldn't want only the net amount to be reimbursed. Mm-hmm. I thought another interesting question was, are only salaries or wages covered by loan forgiveness, or can a borrower pay lost tips, lost commission, bonuses, or other forms of incentive pay and have such costs qualify for the loan forgiveness? Now, I don't think any of our surgery centers are getting tips, but if you were giving bonuses during this period, especially bonuses that you would have normally given to your employees during that, I know we have a couple centers that have regular bonuses based upon performance, etc. So they did verify again that payroll and costs include all forms of cash compensated paid by employees, including these tips, commissions, bonuses, and hazard pay. Again, hazard pay is probably an important element here. I don't know how many surgery centers are doing that, but it is. But remember that all of this forgivable cash compensation per employee is limited to $100,000 on an annualized basis. So for your higher paid individuals, as long as on an annualized basis it doesn't go over $100,000, you're going to be able to be forgiven for the amounts that go up to that $100,000.
And what expenses for group health care benefits will be considered payroll costs that are eligible for loan forgiveness?
So again, the guidance provided that employer expenses for employee health group health care benefits that are paid or incurred by the borrower during the covered period or the alternative payroll covered period are payroll costs eligible for loan forgiveness. However, payroll costs do not include expenses for group health care benefits paid by employees. And again, that stands to reason. So they're only covering the employer portion of it. If it's taken out of the employee's pay, it wouldn't be separately reimbursable. I did find there was an interesting question. So there are certain non-payroll costs that were also covered. And there was a question, is interest on unsecured credit eligible for loan forgiveness? And the answer was no. So payments of interest on business mortgages or real estate are eligible for the loan forgiveness. But if it's an unsecured debt, such as perhaps a line of credit that's not secured by some of the assets of the organization, that's not going to be a forgivable amount. So that might be a little bit of a problem for those non-payroll portions. So this is very granular information. I know, Sue, your head just bowed down and you already fell asleep on me here, but I think it is an important question, and keep an eye out. My recommendation here is that this is a good thing to bring to the attention and to work with your accountant on, because it is confusing. I am a CPA, and I'll tell you, I mean, this is very complex, almost as complex as the IRS regulations for taxes. So I think you're really going to need some help here, and especially given the amount of money that's involved here and the potential for having it written off. Definitely consult with your friendly local accountant to help him through this. Not this accountant, not myself, because I'm certainly not the expert on it. But I know I still get a lot of information from the ASCPA, our organization, that oversees accounting rules in the United States, and they are really working very hard to give guidance to their to their members. So definitely consult with them.
Now, one simple rule, if you've been listening to the news, is don't go out and buy a Lamborghini with the money that you claimed was for your PPP,
yes.
Because you will get in trouble.
And that's probably not going to be forgivable, I would assume. I certainly hope not. Okay, well, let's take a break, and we'll come back, and during our focus segment, we're going to talk about electronic medical record systems. And Sue, you, unfortunately, I recorded this earlier, so you were not part of that recording. Nope. When you and I attend conferences, lawyers are often not very happy with EMR systems. So we do talk about that a little bit, and luckily Daren has a bit of an answer. So let's take a break. We'll come back, and we'll talk about EMR systems.
If your center is like most ASCs, you have seen significant changes in the past several years. Patient financial responsibility is on the rise, while patient experience has taken on greater importance. With margins tightening, physician owners expect their center to run efficiently and on schedule. Competition for qualified staff has left you with a never-ending cycle of onboarding and training. To meet these challenges and more, many ASCs have turned to technology. But too often, implementing technology leads to a poorly connected patchwork of systems from separate vendors that can reduce performance. Surgical Information Systems has a better way. It's SysComplete. SysComplete is a comprehensive, cloud-based technology solution designed for all ASC stakeholders. With SysComplete, administrators and staff use work lists to fly through their scheduling, billing, and revenue cycle management tasks. For physician office staff, SysComplete replaces time-consuming phone calls and faxes with an electronic connection to the ASC that enables them to request cases and share surgical documents. Nurses, physicians, and anesthesia providers say they love using SysComplete for electronic clinical documentation because it follows their workflow. And vitals are captured automatically, enabling providers to focus on the patient, not the documentation. Physicians can use a mobile application to access their EMR for schedule updates and to complete their documentation on any device. SysComplete also improves the patient experience. A surgical portal enables patients to complete electronic questionnaires and review instructions when and where it is convenient. All the information put into the portal flows directly into the EMR for review. And on the day of surgery, clinical and waiting area electronic tracking boards keep everyone informed of a patient's surgical progress. Beltline Surgery's Bill McKnight may have summed up SysComplete best when he said, "With SysComplete, we get the data on the clinical side and then use it for our administrative purposes. It truly does complete our processes and make everything we do more seamless." Learn how SysComplete can meet your needs today and fuel your growth tomorrow by calling Surgical Information Systems at 800-866-0656 or visit sisfirst.com.
So I'm here with Daren Smith. He's the Director of ASC Solutions for Surgical Information Systems. In this role, Daren serves as a product and industry subject matter expert, frequently speaking in industry events and contributing to publications. Daren previously worked as the Director of Clinical Services for an ASC and for a surgical hospital management and development company. Welcome, Daren.
Thank you for having me.
It's great to have you here, and we're talking about an exciting subject today, EMRs, which it's interesting to me, Daren, EMRs really haven't penetrated the ASC market as much as it certainly has in the physician practices and certainly in the hospital arena. So, I thought I'd just start out this interview by asking, why do you think that is?
Well, there was no precipitating event. When we talked about the offices and the hospitals themselves, they had that directive that said, hey, you have to have an EMR. And as per usual, the surgery centers kind of got left behind and they got left out of all of those rules and rulemaking and policies. So everyone said, okay, we're just going to wait and see what happens. So that we really didn't have that drive. Surgery centers are not usually ones that are on the forefront of change either. Most of these surgery centers are using the management products that are 20 plus years old. And that's what they've had this entire time. And new softwares have come and gone since then, and they really haven't gained a foothold in that surgery center community. So they usually aren't the ones on the forefront of change. And we really haven't had that precipitating event that has driven them to adopt these new technologies. And of course, it's not helping when our reimbursements have consistently gone down over the years. So there really hasn't been a flush of money to be investing in new technology either.
Right. And of course, ambulatory surgery centers never had the benefit, you kind of alluded to this, never had the benefit of financial assistance in developing these programs.
So now the focus came back to the companies that produce this software, that now we have to have a massive ROI, a return on that investment. So that takes a little bit of time to develop and a little bit of time for us to find investors that are willing to take that leap with us to create something that has a return on investment so we can encourage people to go down that road.
So, Daren, one of the things that I've always seen over the years in working with EMR vendors is that they often try to sell their products by sending out white papers about how the EMR will save them money. In other words, they do these complex calculations about how much money they're going to save by going with an EMR. And I would argue that never happens. And that's not the reason to be buying an EMR. So I'm just kind of curious your observations about, first of all, those vendors that try to sell their product that way, and perhaps what you think in terms of how they should be marketing their product rather than from a cost standpoint.
Well, in the earlier days of EMR, definitely agree with you. The amount of IT support and the amount of equipment and training and ongoing support that you needed made it difficult to have that return on investment. Luckily, over the last few years, many of the EMR companies have been able to increase that value stack. And we talk about, we used to take some pretty good leaps with that. We used to say, well, all your charts are going to be perfect, so that's going to reduce your liability, and liability is worth what, $50,000 a year? Well, that's kind of a stretch, and we all did it. But now we're able to create a better value stack because we can take this into a SaaS environment or software as a service environment so that we can reduce that equipment spend. You don't have to have these massive servers on site anymore, and you don't have to have as much IT support because the companies that are offering this in a web environment are now handling all of that IT infrastructure and that IT spend. So we've been able to increase that value stack with some other offerings as well. We quite often see with the management products and the EMRs that people were adding things onto it. So they would bolt on a patient tracker, or they would bolt on a communication system that sends text out to patients and things like that. And when they started adding all those things in, they're paying a much higher price to have a more modern system. So what many of the vendors have done is started adding things into that base price so that we can eliminate the need for all of that, all of those additional contracts with outside companies and interfaces and all those things. So luckily, we've been able to increase that value stack over time. I think we're getting a little bit closer to a good ROI, a good return on that investment for surgery centers. Where we see some of those things fluctuate is, of course, at the size of the surgery center. So, of course, the larger surgery centers are seeing a much better ROI than the smaller ones. I know many of us vendors are making changes in the way that we provide those softwares to make it easier and more affordable for the smaller centers too. So it's not a bad way to sell an EMR now. It was a bit of a stretch even 2 or 3 years ago, but moving these things out to a web-based platform has really been able to reduce that capital spend, if you will, and really reduce the amount of training that's necessary. So we are getting closer to a better ROI in that aspect.
But I think that my point is that I wouldn't be trying to sell EMRs on ROI at all. I mean, I think that actually is just not the point at all today. If we're going to sell or try to convince a surgery center that they need to implement an EMR, and I'll tell you from the standpoint of most of my facilities now, the cost is not the selling point. In other words, saving money is not the selling point. In my view, it's the benefits of going to an EMR, like getting better information, maybe more consistency in the documentation. My favorite one, fixing the legibility issue, of course, and making sure that everything is complete. I don't even think that, frankly, vendors and respectfully disagree that selling this based upon on cost savings is the right way to go. I think that we really have to focus on the other advantages and the fact that let's face it, maybe this isn't the best reason to go with an EMR, but this is the way the world is going, and we know that this bullet train is coming at us, and we better be prepared for it. So I think rather than focusing on the finances and potentially saving money, just kind of ignore that part of it and focus on what are going to be the other advantages, particularly in the quality improvements perspective. I mean, this podcast really focuses pretty heavily on quality improvements. So can you just talk a little bit about some of those advantages that we see in modern EMR systems?
So one of the keys that we focus on and we see other vendors focusing on is the concept of better information and consistency in documentation. One of the nice parts about using an EMR, especially the more modern EMRs, is all of the data that you're entering is discrete data. And when we talk about discrete data, that means that it's searchable and that it's reportable. So if we wanted to do a quality study in the past that had clinical aspects to it, that meant we were, taking that massive stack of 60 charts into a room, and I was paying 3 or 4 nurses to page through each one of those charts to pull data from it for my quality study. If we're using a discrete data system, it's a matter of running a report. Right. So we can run that report and have the data that we're looking for. So we're not I don't want to say wasting time, because it's never a waste of time to do a quality study, but we're not using that time to do the data entry or the data requisition. We're actually using the time to analyze the data and use the data to progress that study. We also talk a lot about the consistency of documentation and, of course, the legibility of documentation. And the consistency of that documentation is basically housed within the EMR. So you can get that discrete data option. So if I have a blank on a paper form, I'm allowed to put anything I want in there. But if I'm using a drop down, or if I'm using a radio button that only gives me a limited number of choices, then I can create a more consistent message in my charts and create a more consistent way to search and report on that data. So by reducing the amount of variables, we can in turn increase the consistency of that documentation and make it a little easier for us to do those quality studies and to get the job done. Legibility has always been an issue. You've been in healthcare a long time. I've been in healthcare a long time. I can't tell you how many times I've tried to interpret physician orders and things like that. So that is one of the strong returns we talk about, not just return on investment, but a return on value is that legibility. We also talk a lot about accessibility. And, in a paper world, the only way that I can get a chart reviewed, a chart signed is in a physical manner. I have to be sitting right in front of that chart has to be sitting right in front of the physician or the provider. In an EHR environment, we now have the accessibility that they don't have to be on site, or I don't have to load up 16 charts in my car and drive them over to the physician's office just to get them signed. Now we give them that accessibility through the web or through their phones to be able to jump on there and get those things signed when they're supposed to be signed. So now we're working better towards the timing of those signatures. So we have our orders signed before the case starts, and we have that H&P registered and signed and reviewed before the case starts, and having those things fall in the correct order according to the CMS, HHC, and everybody else's guidelines.
You bring up an interesting point. Right now, peer review is becoming, well, it has been a big topic recently for surveyors, but it's certainly becoming more and more of a topic recently. And I'll tell you, getting chart reviews done, by physician peers is always a challenge. So you bring up a very good point, is that accessibility and being able to do it in a HIPAA secure way is very important. Can you talk a little bit about, how well-designed systems are going to provide that type of accessibility?
Mm-hmm. So when we talk about a well-designed system for accessibility, we want to offer many different ways to access the chart itself. And we also want to be able to control that access. Mm-hmm. Ideally, what would be ideal is I can package up 7 or 8 different charts, electronic charts, send a link to the provider that needs to do that chart review. And no matter where they're sitting, if they're sitting in traffic, they can pull it up on their phone and do that review. If they're at the office, if they're sitting at home, they have the opportunity to do that work when it's most convenient to them. Also giving me that capability of contacting them in several different ways as well. So having the ability to reach out to them anonymously, so to speak. So my whole staff doesn't get their cell phone number. They just have a portal they can go to communicate with the physician. That usually gives our physicians, they're a little afraid of handing their cell phone out to everybody, because they're going to get that call on Saturday afternoon to say, hey, my kid has an earache. Will you call in a prescription for me? Now, if we can do that in an anonymous fashion, it gives them a little easier feeling about communicating with the surgery center.
You bring up a very important point there, too, is that, having a system designed in such a way that you don't have to provide access to every medical record, but only the access to those medical records that you want to have reviewed, need to know type thing is very important. And again, what we're really kind of focusing on here is, what types of things should people be looking for when they're looking into an EMR system. So very good point on that. I kind of wanted to put that counterpoint. So we talked about all the advantages of going with an EMR system, but one of the things unfortunately, Sue is not with me right now. One of her pet peeves when she's looking at chart reviews and a little bit from the medical legal standpoint is that during conferences over the years, lawyers have frequently commented that they would much rather see a paper record than an electronic record, which is always a fascinating comment that I've heard. And the reason for that tends to be the issue of people get kind of sloppy. They just accept the defaults that are in the charts. So they're not going to spend as much time on the drop downs or the default answers, and that's where they get into legal troubles with it. Failure to change the standardized language. So what are your observations about that? And again, focusing on what are good systems out there and what should you be looking for when you're looking at an EMR to assure that you're not going to run into the problems that these lawyers are concerned about? So
probably what the lawyers didn't realize when they were making that comment is when we were on paper charts, we were doing all that stuff anyway. In my surgery centers, I could walk up to a shelf and pull out an op report or an OR record, and it was already 2/3 filled out based on the defaults or the preferences of the surgeon. So we were doing all that work that EHRs are doing now. It just wasn't as obvious as it is in an EHR. So some of that has to do with the visibility of what they were able to see and what they can't see. But to the
lawyer's point, their history in defending these charts are, that they have much more problems defending electronic charts because, as you said, it's so much more obvious in there that they haven't changed those things around.
So a good system is going to allow you to control that on site. So you can make sure and adapt that system to the policies that you have and what do you think is a standard of practice or what your consulting lawyers think is a standard of practice. For example, if I wanted to create in my system the ability to default certain answers to the op note or to the operative record, I would want to make sure that my staff or we were not able to default patient assessments. So
right.
I never want to default something that requires a patient assessment, like an ASA classification or a wound classification. That needs to be entered each time based on your assessment. Safe surgery checklist items, the timeout. Those things are important enough that they should not be allowed to have those defaults or templates applied to them. And it's up to the surgery centers themselves to apply those policies to their charts. Now, a good EMR system is going to allow you to do that. Things like patient position and where the safety strap is and cautery settings and things like that, those were the things that are common and don't change a lot. Mm-hmm. But you can, in the good systems, have the ability to flag those so they require you to at least acknowledge that. So this may be the default, but I'm still going to make you look at it. And this may be what the physician is required to review and sign, but we're still going to make him look at it. We're not going to let him click one button and sign everything without viewing it. So a good system is going to take those things into account and make sure that they have the appropriate security and stoppages and ways to make sure that we're following those policies that ensure quality review of the information and not just flying by those things, which has always been their concern.
Well, and being, it just seems to me like this is one of those areas you probably better make sure that the doctors are not the ones that are making the ultimate decision about how
Amen.
That medical record is going to be put together, because they're going to say, just give me all defaults. So all I have to do is click the button here and everything's there. So we have to protect them from themselves.
And yeah, we've lost as many EMR deals as the next vendor because of that fact. Yeah. Because I'm not going to let you sign off on the H&P without viewing it on the screen.
Right.
Even though that's what you want, because that isn't good for us, and that's what's driving the lawyer's objections.
Yeah, agreed. Well, actually, that brings up another interesting point here is I find frequently we're running into a lot of scenarios lately. You and I have actually talked about this a little bit, where new surgery centers are building or buying systems that had not been designed specifically for ASCs. And I mean, we could do an entire, interview based upon that whole discussion right there. And I think it's particularly acute when it comes to EMRs because of the unique documentation that we have to have. So what I found is that many times when a physician's practice builds a surgery center, they say, let me just use my office documentation, EMR system in the surgery center. Of course, there are no built-in protections there. Can we just talk about that for a second? Is that what is the difference between an office EMR system and a surgery center EMR system? Because they are very different and very different requirements with regard to the sign-offs, for example, the different sections in there, the different type of documentation.
So from a macro level, if we look at this at an overall level, the main difference between the clinic systems and the ASC systems is the ASC system is very episodic. So I come in and have a surgery. You don't have to maintain that relationship and drawing things forward. Most of us are going to have one or two surgeries in our entire lifetime, whereas these clinic systems are designed for the long haul. So they have a very different flow and a very different way in which they approach each individual appointment. That's just kind of on the macro level. On the micro level, if you start looking at what clinic systems were designed to do, was to maintain a patient's health and do diagnosis and things like that. The surgery centers systems we're there to fix stuff. So we want to have an episode of care that concentrates on not maintaining this patient's health, but fixing what's wrong with them. And it's a very different way of charting. If we break it down even further, we start looking at things that are important on the reporting side for the clinic systems as compared to the ASC systems. Clinic systems don't care about inventory or case costing. On the surgery center side, it's extremely important to know whether I'm making any money, what cases I'm making money on, which cases I'm not. So we have yet to see a clinic system that includes an inventory system and a high functioning inventory system and a case costing module so that you have that capability. We have run into hundreds of clinic systems that don't even know what state reporting is. Yeah. So when you start talking about the data that I'm required to keep for my state reporting or federal reporting, you're not going to find that in a clinic EMR, as well as the mandatory logs. So when you are doing surgeries and you have to keep that radiology log of exposure and you have to keep that implant log, most of the clinic systems aren't going to have that. So you're still going to have that giant 3-ring binder with all the stickers in it. And that kind of defeats the purpose of an EMR. If you're going to go EMR, shouldn't you be paperless?
Yeah.
So those are the main differences that we see from that macro level of it's just a different design of workflow, and then down to the micro level of reporting and workflow and things of that nature.
I also find that a lot of those clinic systems, well, actually most of those clinic systems don't allow the proper sign-offs after each section. So like pre-op, intraoperative, post-operative, you're not going to find the right sign-offs there, nor does it accommodate appropriately the different types of providers. The nursing staff, for example, the surgeons, the anesthesiologists. So very good point. And I'm fine. Your point about state reporting is particularly important for me right now because I, of course, live in New York. Quite a number of our clients are in New York. And as you well know, the New York State reporting requirements are probably the strictest in the country when it comes to post-operative discharge information that has to be provided to the state, and none of the clinic systems really can do it as well as a system that's been designed specifically for ASC. So just a note to everybody out there that's looking into a system, especially if you're in New York, make sure those systems have some way of reporting to the state. Otherwise, you're going to be spending a lot of money in order to make up for that lack of information.
We were talking to a client in New York just the other day that was talking about state reporting, and they were using a clinic system. Yeah. And she says every quarter it takes her between 18 and 20 hours worth of work to gather that information for the report. And if you're using an EMR that is specific or a complete system that is specific to the ASC, you're basically putting in dates of service and clicking one button, and it will produce that for you after that initial setup.
You might want a reminder that the requirement in New York now is monthly reporting. So,
yeah.
Good luck with that.
What do we have? 26 states now that require reporting, and some of them are monthly, some of them are quarterly, some of them are annual. So it's not easy to keep track of all that either.
So we're recording this episode during, we'll probably be saying this for the next couple of years, during the COVID-19 crisis. And we're recording this in August of 2020. So we're still in the middle of the crisis, but during the pandemic, we faced a number of challenges with regard to documentation, medical record documentation. And I know from those that had paper records, they had to make a lot of changes to forms, had to add a lot of forms throughout this process. So I guess that's another area that we need to make sure if you're looking into an EMR system, you're able to turn on a dime there and be able to add forms very quickly and hopefully not without any additional expense. Talk a little bit about what we should be looking for in an EMR when it comes to the ability to change documentation, I won't say on the fly, but at least, make it easier for those changes to occur.
Yeah, you want to make sure that whatever system you're evaluating has the ability to provide you with a forms manager. A forms manager is going to allow you to add questions, redesign your forms, and redesign in what order those fall within that perioperative visit, and giving you the ability to do that on site. So having the appropriate controls so someone can get in there and add that COVID antibodies question to the questionnaire. And I would also add that if you want to take that one step further, make sure that the system that you're looking at gives you the opportunity to do that in a remote fashion. Mm-hmm. So having the ability to bridge that gap between you and the patient remotely. So having the ability to interact with the patient over a portal or interact with the patient via text or email can be very important as well, especially in these times. Getting that information without the patient standing in front of me has skyrocketed in its importance.
Well, and that brings up another interesting point, is that as we're transitioning to this new world, we're finding that our HMPs are going to be evolving also, and that we're probably going to be doing a lot more telehealth. Particularly, I can't do a physical very easily, though I think that will be changing too. But definitely gathering the history. And a lot of surgery centers over time have, made preoperative phone calls, to patients. But that would be between the nurse and the patient. I think we're going to find changes with regard to the HMPs in general, and how that information is being gathered through telehealth and a direct interaction between the physician and the patient through telehealth.
Mm-hmm. And whatever telehealth solution that you look at, make sure that telehealth solution has the ability to drive information back into your EHR.
Right.
So you're not, creating more work for yourself by now I have this report that I have to take all the data off of and put it into my EHR.
Right. As many of our clients start to consider implementing EMRs, one of the issues that they run into is the time frame. In other words, how long is it going to take to, first of all, make the decision to implement an EMR, to choose an EMR, and then implement an EMR. And I think it's important for us to kind of set those expectations properly. The reason I bring this up is I had a client, I think it was yesterday, who said to me, "Yeah, we hope to have this EMR system up and running in a month." And so what do you think about that? What's your advice? By the way, they are one of your clients, so.
So it's possible. It's not impossible, but there are so many variables that you have to take into account. So let's start with that evaluation process. Of course, the evaluation process now takes a lot longer than it did a year ago, because there are certain things that we were able to do a year ago that we can't do now, like come on site and be able to do a demonstration in front of all of your providers at one time, or make the rounds while we're on site. So we're doing all of that virtually now. Mm-hmm. Site visits. I think it's extremely important that you, at the very least, talk to someone who's using the system now, or if you have the opportunity to go on site and watch them work within the system. It's one thing to have me do a demo for you, because I live and breathe in this system, and I had a hand in designing a lot of the system that you see. It's one thing for me to be able to show it to you. It's one thing for you to see an end user having the experience in the system. So those things have become more complicated in this evaluations phase. The typical evaluation that we're seeing takes about 4 weeks. It's a little bit longer now, because now we're doing virtual site visits and things like that. But around that 4-week mark is pretty good to make your decision. Once you've made your decision, that next phase of contracting depends on how much you want to change within that contract. That can be as short as we present you with a standard contract, you sign it that day, and it's a one-day process. But if there's redlining and if we get lawyers involved, of course, they're looking for those billable hours. So we see the complications explode from getting the lawyers involved, and then our lawyers have to get involved, and it can be weeks or months to get through that contracting phase. But once we have a binding contract, what we're seeing right now is somewhere between 8 and 12 weeks from the point in which that is a binding contract until you're able to go live. And of course, the variables that come into play during that 8 to 12 weeks is how much time does your staff have to dedicate to the building of the system and the training on that system. And the other variables that come into play is how many physicians are you servicing at the surgery center? How many physicians visit the surgery center on a regular basis? Because some of the biggest parts of that build are the preference cards, the order sets, the discharge instructions, and things of that nature. So those are very physician specific. Those that want to shorten that time, if you have dedicated individuals at the surgery center that can give time to the build and training process, that will move your project along quicker. If you already have those order sets, those discharge instructions, those preference cards in a printable format and an Excel format, a Word format. Make sure that the EHR you're choosing has copy and paste capabilities so that those things, you don't have to spend all your time typing all of that information out. So if you can take care of some of those variables by getting that information ahead of time, you can shorten that timeline. I know many vendors, ourselves included, use the super user methodology, where we want to provide additional training to a few individuals at the surgery center so that they have the opportunity to, or the security rights to go in and change things. They're the person people go for that first line of support. They're the person that has the ability to orient someone when you have new employees. So that super user should receive somewhere between 8 and 10 hours of personalized instructions so that they have an idea on the inner workings of the system, so they can be the one that jumps into the forms manager and adds that COVID question so it starts showing up the very next day that you're starting to look at charts, that can change those physician orders and op notes and be able to handhold some of your physicians that are going to be adverse to the EMR. The end user training has gotten a lot better. In the older systems, our end user training was 6 to 8 hours. So you were dedicating an entire day to end user training. Luckily, we've been able to engineer a lot of that training out so that our end user training right now is averaging about 2 hours. So we have 2 hours for end user training for nursing staff, anesthesia. Our physician training, we've been able to reduce that down to about 30 minutes. So having a system that's able to engineer out a lot of the variables or construct the architecture in a way that it flows very easily can really reduce the amount of training that's required for your staff.
I think one of the points I'm trying to get to also is that there is no compelling reason to rush this, especially at the expense of quality of doing it right. A poorly implemented EMR system is worse than no EMR system at all. And it's important that you make the time to do it right. As you said, I mean, in training, we all know how important training is to every aspect of ASCs. But you're setting yourself up for failure if you artificially put a timeline that is just unrealistic, and making sure that you have a proper amount of time for that training. I also want to go back to one of your points earlier. I'll go so far as to say, do not buy an EMR system without going and visiting an actual end user with it and having some time. And the good systems out there, of course, will gratefully give you end users that you can visit, hopefully near them. But there's if you don't actually talk to somebody that uses it on a daily basis, that you can actually see it in action, you're setting yourself up again for failure on that. I think a lot of the systems that I've seen implemented recently have exactly had that problem, that, they've gone through the sales pitch, they've listened to the vendor talk about the value of the system. Sometimes the doctors are the ones that are making that decision because they had the sales pitch over the phone or whatever, without actually going into the details of it. And I think that's a bit of a challenge in making that decision. I'll be honest. I really think that if you're going to implement a system from the beginning to the end, the minimum amount of time is probably 6 months to between when you decide that you're going to go with EMR and then actually, going live with it. And my experience of implementing computer systems will default back to that. Make sure that you have an overlapping time frame, where in the case of an EMR, you're doing paper records for a short period of time. At the same time, you're doing an EMR, and then have somebody compare those records to make sure that you're capturing all that same information. It's difficult, of course, especially with an EMR, having to duplicate that effort. But you do need to think about that when you're implementing.
Yeah, we always try to make that very clear when we're talking to people. Is if any salesman comes in front of you and says this is an easy process, they're lying to you.
That's right.
Because it's not easy. It's not easy. It is challenging, but hopefully, especially in the recent past, we were able to show you how much effort you put in now has exponential results later.
Right.
So if you do the right things with training and with setup, and when you're going through that implementation phase, you're building things the right way. The most expensive EMR you're ever going to have is the one that you install second.
Yeah.
So doing it right the first time, investing the time and energy in it now is going to have exponential results in the future. So you don't have to redo all of that work. So listen to your trainers and listen to your implementation specialists and make sure that you're investing now.
Yeah, and to that point, we have a client, unfortunately, who did not take that advice from either you or the vendor, and they are on their third EMR system in 18 months. And by the way, they've gone back to one of the systems that they used in the beginning, which wasn't a great system anyway. And by the way, none of these systems, I guess I need to point out, none of these systems are ASC specific. So they still keep making the same mistake over and over again. Part of the problem is that they are, just like we talked about, they are a clinic / surgery center also, which, provides a lot of challenges. I certainly understand how you want to reduce the number of systems that you have out there, but you shouldn't be doing that at the expense of having a system that's designed specifically for ASCs.
Yeah, and that's always been the challenge for those those centers that, they're open 1 day a week or 2 days a week. And then, we ride in there on our white horse and say, hey, we've got the perfect system for you, but we can't price it in a way that's advantageous to a small center. So, right. That's been on our plate for quite a while, and we're making some changes to make it more efficient for them. It was never easy to walk into those centers and say, oh, by the way, you have to buy a $25,000 server in order to make this run, for 1 day a week. So that's part of what's driven the innovation of the EMRs and management systems the last few years is trying to get down to that market.
So let's finish this interview with, let's see if we can do this, like a quick bullet point list of what should a center be looking at? What are the most important things they should be looking at when they're looking at an EMR system, bullet point wise? Otherwise, we would have another 2-hour interview here.
I'm going to say the most important bullet point that I can advice that I can give anybody is workflow. Make sure that this workflow is efficient. Make sure it's efficient not only for the workflow in the business office, but the workflow for the clinical staff, for anesthesia, and for the physicians. Make sure that they have the appropriate tools in the system to accommodate an ASC workflow. Okay, so that's problem number one or bullet point number one when evaluating. Make sure that when you're evaluating these systems that they're going to be around for the long haul. As you know as well as I do, we've seen a lot of systems come and go in the marketplace, and making sure that this system's going to be around for a while is going to be important. And third big bullet point is security. If your EMR vendor can't provide you with security documentation or a SOC 2 certification that EMR vendor has gone through SOC 2 certification, you need to get them out of your door right now, because they're not able to provide you the security that's required. We've all seen the Becker's headlines. This place was had ransomware, or this place had an interruption in service. If you look at all of those headlines and you search to see where those are all on-prem solutions or server on-site solutions. So we know where the vulnerabilities are on those on-site systems, and making sure that security is high on their priority list as well. So those are probably the three biggest bullet points I can give you as far as what they need to be looking for and what needs to be considered when they're looking at EMR in the surgery center.
This has been great, Daren. It's nice to every once in a while we try to talk about EMRs. I know it's not everybody's favorite topic, but I think it's going to become even more important in the future. I think we are, as an industry, running out of time to move in the direction that really all the other organizations have run. So I think this is very timely advice. I really appreciate your time.
Thank you so much.
You're never alone in the ASC industry. Many organizations are eager to provide an opportunity to keep up on all aspects of running an ASC, and in this section we highlight upcoming events.
So as we mentioned before, we're not getting a lot of information on these things. So fortunately, I know about a number of them. So please, if you'd like to have your event included in our podcast, please send the event information to info@ascpodcast.com. And we would graciously love to include you in this list here. It used to be that this list would take us, quite a while to go through. But
whether it's virtual or live.
That's right, any of them. So the New York State Association of Ambulatory Surgery Centers will hold 4 virtual conferences. We're going to be managing them out of our studio here in Spencerport. They're going to be on 4 days in September: Monday, September 14th, Wednesday, September 16th, Monday, September 21st, and Wednesday, September 23rd. And they're going to be in afternoons just to make it a little bit easier for administrators. Hopefully all the fires will be put out pretty much by then, or at least be only embers at that point. And for more information, visit nysaasc.org.
California Ambulatory Surgery Association has gone big time into the virtual conferences.
So I had an opportunity this last week to talk to Beth LeBoyer, and I know she's been working very hard in getting all these things done, and she's done a fantastic job of putting together a whole series of upcoming virtual conferences, a number of them that have been done already. For example, today, August 5th, she did a session on medication management in 2020, which I'm sure was great. But
their live conferences are always so good.
They are. Oh, I know. I really miss going. Well, first of all, I miss going to California anyway, but to be able to see these virtually, I think will be fine. And I'm going to be doing an exciting ASC financial boot camp on Friday, October 9th for her. So definitely go to casurgery.org for more information. That's casurgery.org for a list of all the upcoming virtual conferences put on by CASA, and certainly to sign up for my ASC financial boot camp, which I'm sure will be a big success. And the great thing, you mentioned it earlier, too, is that you don't have to be from California or for the California Association to sign on to it. I don't have the pricing information on this, but definitely go up there and check it out.
And the Ohio State Association Conference will be September 30th through October 1st, 2020 at the Hilton Columbus Polaris in Columbus, Ohio.
So Alex and I are already signed up for that. It does sound like it's going on. It does sound like it's going to be live. So I haven't heard any changes to that at this point. As I said, I just saw that my hotel reservation came through. So I'm sure that will be interesting. That is the only live conference that I'm aware of at this point.
Yeah.
Well, that's it for this episode of the ASC Podcast with John Goehle. Join us again, and please consider becoming a patron by going to our website at ascpodcast.com and spread the word about our podcast with your friends and colleagues, and certainly do us the honor of hitting that subscribe button. The sound editor for this episode is Susan Cronkite. Executive producer is John Goehle. Research assistance is provided by that incredible team over at Ambulatory Healthcare Strategies: Susan Cronkite, Jenna Alvarez, Judy D'Ambrosio, Alex Borneman, Zach Calritis, and Lori Rodericks. Music is provided by Media Sushi and Mike Noah. And the ASC Podcast with John Goehle is hosted on Podbean and is available on all major podcast channels.
This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. We would like to thank this week's sponsor, Surgical Information Systems. SIS provides cutting-edge information solutions for surgery providers. For more information, visit sisfirst.com. If you're interested in advertising or sponsoring with the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.